We'll start the Human Services Committee meeting. Kerry texted me, said he was going to be a little late. He had a doctor's appointment that he might run late at, and Ron will be presidentially late. So we'll get started. No courtesy of the floor? Any? No? Okay. Julie, you're up. So if you want to introduce yourself. Too bad Kerry's not here, but, you know.
Okay, I am Julie Bader. I am slated to be the administrator for children and youth starting on Monday. And I was asked to come and introduce myself, so I'm not sure if you have specific questions. I've been at Children and Youth for almost 19 years. Prior to Children and Youth, I worked in the Lehigh Valley, ran a in-home mental health services, outpatient services, family-based. We had adult services when Chip was first around. Ran that clinic for 8 years. Well, I started as a TSS and ran into management there. And prior to that, I worked in partial hospitalization in Luzerne County for 15 years. So I have about 20 years experience in mental health and 19 here at Children and Youth now. So looking forward to taking over. Nervous about taking over. Kevin has big shoes to fill, but hopefully we can keep it running in a positive direction and keep moving forward. With luck, I hope to have fully staffed. I know we're looking to leave civil service, and that presentation we did last year, a few months ago. I know the letter is out. I'm hoping that will help. Right now we have 15 vacancies at Children and Youth. We just filled and started to backfill some of the promotional positions that we got through you guys last year. So we now have an extra person on our administrative team. We've have 4 program directors for the first time. The assistant administrator position is in the works. It's out at civil service for certification, but we hope to backfill my position as I fill into Kevin's. And we have 2 or 3 casework positions that are on right of return because of promotions into supervisor positions as we backfill the people that we're promoting. So I have 11 that I could fill as soon as I get a civil service list. I have 3 that are Spanish speaking that we're trying to fill, also waiting on a civil service list, and the rest is in the works. And I don't know if you have specific questions for me.
Well, I honestly just wanted you to be introduced, but if anybody has questions, that's fine. I guess my question would be, when would you want to come back and give us like a more full report? Because I didn't want to smack you in February. Like, but it's always good to hear what the updates are. You know, I know with Sandusky, paperwork and all that's been hard. I guess as civil service progresses, you'll have updates on that as well. Correct. So May, June?
May, June will be about the time we're writing our budget, so that will be pretty good.
Okay.
We should have more information on some of the Family First things that are rolling in October as well. So we should have better ground on where we're going with that as well. So yeah. May, June. June is when our budget's due for the state. So
good.
That will be fine.
Welcome.
Well, thank you.
Glad to have you.
Thank you very much. All right. Thank you.
How are you?
Human Services Director.
Hello. So you met Julie. Most of you have before. Kevin's retirement party, hopefully everybody already got their notice, is tomorrow. I believe it's at 12 o'clock in the Human Services building for anybody who would like to go. We will accept those even who have not RSVP'd, I promise. So if anybody's interested, you're welcome to attend. Some good news to share tonight or this afternoon. I'll start with our aging division. We, as folks might know, just opened 2 new senior centers. We finally have our people out of the old Easton Fork Senior Center that was not a good place for them to be any longer, and opened the new one. And it is actually in an old Bounce U building, so like an indoor jumping fun zone kind of thing. Bounce U went out of business in that in this little strip mall or bigger strip mall kind of thing. Perfect. It's amazing. It's huge. It's beautiful. They did a phenomenal job. You absolutely should see it. No, but that's an interesting idea.
It's a senior center.
Some of
The
those
liability
folks are
of
pretty
that. I just
feisty.
thought of all the liability of that.
That is good to know. We have 2 pool tables. We have a sewing room. I mean, it's a shuffleboard. It's amazing. You absolutely should go see it. There's still those high ceilings because it was bouncy, so we're working on seeing if our O&M folks can figure out some noise reduction because of the echo. But it's amazing. And then we also opened the much smaller but equally nice center in Lower Nazareth. Lower Nazareth Township, Old Township Building.
Yep.
The Bath Senior Center I had reported months ago was also in a state of, not disrepair, but it was just not in good condition. And some new folks finally took over that building and are going to do what they're going to do with that. So we had already been planning the Lower Nazareth Center, so it was a perfect time to transition folks. And I'm very happy to say that every single person from the Bath Center has been attending the Lower Nazareth Center. 4 of the folks who needed transportation, we are sponsoring them on Lanta. So in addition to that, we've also picked up some new folks who are closer to the Lower Nazareth Center. So you should check that out too. And maybe you should go there first and then to the really big one. And the senior centers, they go through an annual monitoring or inspection just like all of our other folks. And Kim Nichols took that over just about 2 years ago, and since she took over, the feedback has been exceptionally positive from the state. Some of the comments that we just got, that Kim specifically got, it is amazing to see all of the work you have put into strengthening the health and wellness programs in Northampton. It's particularly exciting about your reaching out to the Hispanic Center of Lehigh Valley. This is amazing. So Kim has just done a tremendous job with all the senior centers, as have her senior center operators, who are the folks who manage those on a day-to-day basis. So that's really fantastic for our seniors. Our options program in aging, which provides, it helps set up community-based services for folks. So for folks who are still able to live at home or with a relative, the options program can help set up services that folks might need in their home, whether it's shopping or bathing, any kind of personal care tasks. We had our monitoring there as well, and that is a division that had been down 2 or 3 staff out of 5 for a little while because of retirements and some different things. And our supervisor for that division, I think she's still been there a little less than a year, but somewhere right around there, has really done a tremendous job. We are just now officially fully staffed in that division. Somehow they managed to hang on by a thread all that time, and they were monitored and scored a 96%. And although it's not official, it's a green. So we're another program in the green for aging, and some of the comments they received from the Pennsylvania Department of Aging were well done, commendation on a great job, commendations for making needed changes. Your management team is very strong. They really made a lot of changes in a short amount of time, and they're rocking it. So that was exciting. I know Ms. Vargo Hefner likes her data, so I got one of the things that my deputy, Robin, who couldn't be here tonight, we'll have her present maybe at the next one, is working on is helping each division decide which outcomes we would like to track. And our divisions are all already tracking different outcomes, but the difference is this year, if we can pull it off on time, we are actually putting that into our contract language for our providers so that they have to submit certain reports that we don't necessarily have access to, and we get the data that we want, not just the data that they would like to present to us to show us how great they're doing. So one of the stats for aging in protective services, we talk about the call volume for children and youth. Aging, is the raw numbers are much lower, but from we pulled the info from the first quarter of fiscal year 1920, so that July through September, and the call volume increased 19% from the prior fiscal year already. The state overall volume increased 9%. So we're still almost double the increase in what the state is even seeing overall. But amazingly, because we are down 2 staff in that division, one is a new position that we're finally, it was posted, we're interviewing and filling. The other one we filled tentatively, and civil service, it was literally a 2 or 3 month process for them to say yay or nay, and then some circumstances changed, so we're still back to filling that position. So we thank civil service for their efforts there, but we're working on that. So even despite that, we are still at Northampton County, our investigation start times and finish times are still better than the state average. So again, they are holding it together there. And we have a new investigative / risk manager nurse at Gracedale. And she and Dawn, the director of nursing, met with Lori Greco, who is our aging administrator, because there's a lot of collaboration between our aging department and Gracedale. And it was really funny after their meeting. Both Lori and Dawn were texting me about how fabulous the other was. So it's even not just within human services. It's our Gracedale folks and our human services folks can collaborate. So so they're getting the ball rolling as well. And then do you have any questions about that? Then I just have a few Gracedale things. Otherwise, okay. So I think I have mentioned here that I have asked and have started to receive a monthly report from our recruiter, Victoria at Gracedale. So I just got January's, but December's, she provided the outline of all the things that she had done and all the places they had been. And then in January, she shifted her focus to proactive recruitment and relationship building with prospective applicants. So she's really doing a lot more when we get an application for an LPN or an RN in particular, because those are the positions we are most in need of, although we always need aides. She's calling them personally and having those more personal conversations. So I think this was through what day is today? Thursday. Through Monday or Tuesday of this week. Between January and February, so far we have hired 13 CNAs. 8 are trainees, 5 are hired already. So hopefully we'll get a fair amount of the 8 that are trainees. We have hired 7 LPNs, 2 RNs, a nurse supervisor, and 2 dietary aides. And I don't have the email with me. I believe we just added another RN as well. So we went for a very long time without being able to make any movement on the RN radar, and we're starting to move that needle a little bit. So we're really excited about that. We have talked about Haven House and the program that's at Gracedale. And for folks who don't know, Haven House is a behavioral health, mental health agency, and they're providing services in Gracedale to our residents that consist of individual therapy. They're going to start adding group therapy, and they also have certified older adult peer specialists. So it's an older adult who has some kind of mental health issue and is exactly what it is. They are a peer support for our residents. And we asked, I know Ms. Vargo-Hefner had asked about our call volume from Gracedale to our Iris division. And so I got those numbers the other day. So we implemented Haven House sometime in 2018. In 2017, there was 31 calls from Gracedale to our Iris division. And these are solid rough estimates because it depends how somebody codes a phone call. So I'm not saying that it could be off by 1 or 2, but it's a good solid rough estimate. That's good.
Is that a mathematical
Coin
term?
that?
That's a finite term, right?
Solid rough estimate.
Yep. It's more than a rough estimate. It is a solid estimate. I'll take out the rough. So we had 31 calls to Iris in 2017. We had 27 calls in 18. And in 2019, we only had 20 calls. So there are we know this, we talk about this, our folks with mental illness at Gracedale. We're always going to have phone calls. We're always going to have folks who need to be evaluated at the hospital, maybe psychiatrically committed. That will never change, but seeing less of a call volume to Iris means that our folks are better managing and working with our residents, and they're not having to call for assistance from our crisis line. So I was excited to see that. And then lastly for Gracedale, we spend a lot of time talking about our psychotropics, our antipsychotic meds there. And during QAPI, I keep seeing this slide, and I had asked Melissa Schaefer, our quality assurance person, to have a copy of it to present to council. So what you're, well, I'll wait till it gets around.
It does look like Dr.
It does.
What's that?
Looks like a Pink Floyd album cover.
There you go. So
If you're old enough to know which one.
I've heard of Pink Floyd. I don't listen. Anyway, this slide talks about antipsychotic use from 2015 to 2019. The blue line on the bottom is our, it's the lighter blue, is the antipsychotic use in 2019. So we've talked about how much we've reduced our use of these meds, and I know last month or the month before we talked about a slight uptick, which is accurate and also not uncommon for the winter months. But compared to 15, 16, 17, and 18, you'll see that for the last 4 or 5 months of the year, we were still well below all of the other years. And this is a concerted effort, of course, being discussed at QAPI and amongst nursing staff and our docs. So I just thought that would be a good visual for folks to see that we really are, you know, comparatively speaking, doing very well in that. And of course, we will not be resting on our laurels, and we'll continue to work on that. So that is all that I had for this evening.
Any other questions?
The new centers, the aging centers, how's the access to that? I mean, how does the community get to know, and is there a fee for the senior citizens?
There is no fee. I'll answer that part first. Each senior center does take donations for people who are able to and interested, but that is funded through our aging block grant. And that's a good question. How do people know? I ask that about every service that we provide at the county, and the answer tends to vary. But this point, it's probably a lot of word of mouth. I know there's been some, you know, we certainly advertise or post on Facebook, and, you know, Becky Bartlett does that for us. Always open to new ideas or suggestions if folks have them, though.
But they're used well?
Yes, and it certainly varies from location to location, but I think there's only one senior center that has low attendance, and there's multiple factors, and so it's not something that we can even necessarily change. And other than that one center, they although they fluctuate depending upon events and what's going on that particular day, what they're having for lunch that particular day, it's totally true.
That would do it for me.
Yes, me too. Yeah. And I don't know if you guys know this, but Gracedale actually makes the food that we serve at our senior centers.
Oh, nice.
So we're able to purchase it from them at a better cost. I don't know the answer to that. That's a great question. I'll find that out. I don't know. I just know it depends. Yeah, we'll bring Kim Nichols one of the times, our senior center manager, because they do so many things that I couldn't even begin to touch upon. That when I first read the report last year, I was blown away at how much that they actually do. So,
One more, please. Did we get any referrals from our own employees, that new procedure we started? Did we get anybody recommending?
oh, I don't know the answer to that. I'll ask HR and I can get back to you. In terms of current staff,
bringing some of these
Yes.
RNs in? I mean, those are pretty good numbers. I'm just wondering if.
I have not heard that any of those were referred internally, but every time we meet with the unions and they ask what we're doing for recruitment, we also remind them about the referral bonus.
Good.
So, but I can find that out for you.
Thank you.
You're welcome.
Oh, Sue, could I ask you if you have any more openings of senior centers or anything like that, grand openings, could you inform council?
Oh, like of the grand openings?
Yeah, openings. Like you had an opening in Forks, you had another one, and we found out after the fact, but,
I will accept fault for that.
well, no, I'm just asking.
I apologize about that.
It's okay. No, it's an old,
Go for services and taste the food.
it's an old courtesy that was extended to council.
I don't
That's
mean to
okay.
make light of your request, I agree.
No, you are
Any other events that you
absolutely
think we
correct.
should know?
It was simply an oversight.
No,
I'm going to
I'm
drill
not
it into my,
picking on
no,
you.
what I
You're
feel
not the only
badly, this
one,
is,
but-
I feel badly about that. I apologize. You're welcome.
I just want to let you know that I am now sending all of the press releases to Linda, so she can distribute them to the council.
Previous to, or before there is an actual event?
Yes.
Okay, thank you.
It's always on Facebook before, too.
I don't.
Mr. Heckman, we got to get you a Facebook account.
It's there.
The Forks thing I didn't see until after the fact. It showed the picture of you standing there, but I didn't see anything before.
Posted on Facebook before that.
Well,
But it's well understood, and
I
it's
mean,
going
yeah.
to Linda now in
I
advance.
don't think council should have to hunt. I don't think many other people have to hunt.
Well, it sounds like thankfully, and I appreciate that, Becky, we'll get the press releases to you all, but I will also remind my folks about that as well. It's just one of those oversights. It's not, I apologize.
That is, I figured it was an oversight.
Any other questions?
Just one quick one. The governor put out his budget. Have you had a chance to analyze it and how it'll impact your department?
Not significantly. I have a phone call in a week on next Thursday with the equivalent of this Mike CCAP people who are going to talk about it. I know he did. I think the quote was he raised increased the budget for the options program in aging by $8.1 million. I think the hope was that we were going to be able to take about 4,000 folks off the wait list statewide. I don't think that total factored in the fact that we would need additional staff to, not us per se, but other counties would need additional staff to case manage that. But the goal is certainly to get more folks off that wait list, which should at least make a large dent in it. That's the one line item I've heard of specifically that will impact us. Otherwise, I haven't heard, sort of no news is good news, or not, but it's stable. I haven't heard of any cuts, I'll say that. Certainly could use some increases. Thank you. Sure.
I have two questions. What update do you have on the civil service process? Because Julie mentioned it, but
She did. Georgine, my fabulous assistant, confirmed earlier this week that, actually she confirmed last week, that application is in the hands of the Secretary of Human Services, Teresa Miller. So I asked her to follow up next week with that office I'm not sure now what the next steps are, and so I asked her to follow up so we can get contact info of, who we call, how long should it take, who can we bother when we don't hear anything. So I hopefully will have some news next month.
okay. And any updates on the mental health adjudicated grant that we have?
The forensic grant, the ORLTSR.
Yep.
Outpatient rehabilitative long-term structured residence. That's good. It's a mouthful. Yes, that went to zoning on Tuesday in Easton and passed unanimously quickly. Pastor Phil Davis from Shiloh Church had a contingency of about 30 folks. I heard it was standing room only in support of that. So that is a very significant hurdle we crossed. And we have many more to go, but that was a huge one that Pastor Phil did a great job with folks to get through. So we're working on contracts for construction, which are not done yet. There's still conversations with the solicitor's office. We need to meet with the judges and court administration, pretrial folks, to solidify procedures and how it will really roll out.
So could we get a report like in April or May on that?
Yeah,
Like
sure.
from origin to up to date?
Yep.
And I think that's the only questions I had. Anybody else? Okay.
Okay.
And
you.
now we're up for Gracedale.
Gracedale.
Good evening. While Brian hands out the paperwork, I'm going to talk about our survey that we had and how great the team at Gracedale was during this survey process. And over the last year, we have come from 11 deficiencies to 4. So the 4 deficiencies were so out of 700.
Just wait a minute.
Yep.
Let him do this because what you're going to say is important. I don't want it to get distracted. Go ahead.
Okay. So about 700 employees, and we had one employee who had a surveyor watch everything she did, probably nervous, forgot to wash her hands in between. One employee. So we did get dinged on that. So the one employee we got for hand washing. We had a new RNAC who was in, and she forgot to send out a non-Medicare coverage letter. So that happens when somebody is done with their therapy, Medicare is not going to pay anymore, a letter goes to the family and says, you know, you're being cut from Medicare. That letter was not handed to the family. Family had no recourse, they had gone home, they were finished with their therapy anyway. So we did retrain on that one. The 2 things that we got dinged on that are very important are the non-pharmacological interventions for pain and psychotropic medication usage. So we do it, people did not document it. So if you didn't document it, it didn't happen. So that could be offering some kind of relief other than using medication. Cup of tea, a back rub, something, a pillow. They just didn't document it. So we work with point-click care to create an easier way for everybody to record what they do.
Click.
Yep. So those were our 4 deficiencies for the survey.
So there were 2 non-documented.
Right, so each one counted as 1. So while they were in for survey, we also got 4 complaints at the same time. 3 of the complaints were unsubstantiated and 1 was not. We had a housekeeper who thought she was doing the right thing, and we had a resident ask for spray to alleviate a smell, and she handed it to him, and he sprayed it in his room and got it on another resident. We had already taken care of this. We had counseled her. We told her we in-serviced the whole department, but they still did ding us on that. But we did everything that we were supposed to do. And she was very good employee, so we were saddened by this. But the team did a fabulous job over the last year. I mean, we have looked at every department. We have looked under carpets, rugs, everything, just to find out where we needed to concentrate on. And we thought survey was it. We wanted to be sure we got our survey down, and it looks like we did. So I'm very proud of the team at Gracedale and everything they've accomplished.
Any questions on the survey?
Okay, before we start on the dashboard this month, I know that kind of the topics of PDPM and CHC and what they are have come up. So I have a brief overview in your packet kind of explaining the 2 programs a little bit better. I'll start off with the PDPM, which is the patient-driven payment model, which took effect October 1st, 2019. Just a little bit of a little side-by-side comparison. The previous system that we were under was called the RUGS 4, RUGS standing for Resource Utilization Group. And in that, there were 5 assessments that were scheduled. The rate would vary based upon the 5 assessments. And therapy minutes really were the main driver in what determined the reimbursement rate. And there was no reduction in the rate during the duration of the 100 days. Now, with PDPM, conversely, there are only 2 assessments. There's one assessment that is due 5 days into a person's Medicare A skilled stay, and then there's a discharge assessment that's required that essentially recaps the entire period. There are optional assessments, but they are not required. The 5-day assessment, which is the first one that needs to be done, essentially sets the entire reimbursement rate for the entire stay, so it does not fluctuate as in the other system. Therapy minutes really do not drive the reimbursement rate like they used to. They do essentially more of the therapy that the resident receives, and their various scoring on things is what drives it more, not how much they get. And there is a variable rate, and there's a 2% reduction to 2 portions of the rate calculation. So if you flip over here again, just to show the components of what makes up the 2. Under the old system, like I said, therapy was really the main driver, and it really only looked at therapy, how much therapy they were receiving, and nursing. And essentially, there were only 66 possible categories that someone could fall into under this system. Under the new system, there is a physical therapy, occupational therapy, speech therapy, nursing, non-therapy ancillary, and non-case mix categories that all combine to determine a rate. Now, I did not calculate this. I will not take credit for this, but they say there are 28,800 possible combinations for reimbursement rates under this system.
Yes, everything's worth a point.
So if you flip to the next page, this essentially gives you more of a visual representation of the different categories and how the factor for each of these categories is calculated. Essentially, then once you have your dollar figure for each one of these categories, you add them up, and then that is your rate that you receive. And the true essence behind it is to make the program more specific to a resident and their individual needs and their diagnoses and conditions, as opposed to just how many minutes of therapy do you get. So you'll see there on this slide that there are adjustment factors within the rate for the physical therapy, the occupational therapy, and the non-therapy ancillary categories. If you flip to the next page, this shows you what the adjustment factor is for physical and occupational therapies. Essentially, after day 21, every week, that portion of the reimbursement rate is reduced by 2%. Until if someone stays for a full 100 days, we are only receiving 76% of the reimbursement for those categories. Now, the logic behind that is that as someone progresses through their 100 days, they should require less intensive therapy, so because they should be making advancements. If someone does not make the advancements in therapy, essentially that is when someone can be cut from a Medicare A, and that's essentially saying that they've either plateaued or they're just not benefiting from the services that they're receiving, so Medicare no longer will essentially reimburse for those benefits. The next slide shows you the non-therapy ancillary adjustment factor. Now here, in the first 2 days, we actually get 3 times the rate for this adjustment for the factor of the non-therapy ancillary. But then after day 3 is where you only just get 100% or 1 times the factor.
Is that assuming that they're spending more time assessing?
Correct, yeah, in those first 3 days, yep. It's Medicare oversees it through the 5-day assessments, and those are controlled, essentially the MDS, which is minimum data sets. They are submitted by the RNAC nurses. They're the registered nurse assessment coordinators, and they essentially compile all of the data into this report that has to be submitted within those first 5 days, and then all the information within that is what calculates our reimbursement rate. So to break down just each one of those categories, just to give you a little bit more information into what's all involved here. For the physical and occupational therapy categories, I know previously at other meetings I've talked about ICD-10 coding, and that is the new coding format. We do, like I previously said, we do have employees that are certified in this. All of the RNACs have a very strong grasp of this. Essentially, every primary diagnosis is assigned a code. So for these two categories, we need a primary ICD-10 diagnosis coding, and then those codes fall into 4 categories. Those being major joint replacement, other orthopedic, medical management, or non-orthopedic surgery and acute neurologic. And then there is functional scoring. Now here, this is where the therapy factor comes in more. And this is one schedule within the MDS that the therapy department is in charge of coding. And what it looks at is a resident's ability for self-care and mobility. Items like eating, oral hygiene, toileting hygiene, and then mobility factors like sitting to lying positions, lying to sitting on the side of the bed, chair to bed transfers, toilet transfers, walking 50 feet with 2 turns, and walking 150 feet. The speech category looks at 3 areas. Again, this is looking at a resident's diagnoses and their condition. And it looks for the presence of acute neurologic conditions, presence of speech-language pathology-related comorbidities, which could be anything like oral cancer, dysphagia, traumatic brain injuries, and then if there's a presence of a cognitive impairment. The second area that this category looks at is the presence of a mechanically altered diet, or if they have a swallowing disorder. The nursing category, again, starts off, and this looks at the same exact areas that the physical and occupational therapy looked at with the self-care and the mobility, as well as if the resident is receiving restorative nurse services, or if there is a depression factor with the resident. Non-therapy ancillary. Essentially, there is a predetermined list of possible comorbidities, and they each have a point associated with them. The more points that you add up, the higher that the reimbursement factor can be for this category. Some examples of the comorbidities are COPD, cystic fibrosis, morbid obesity, cirrhosis of the liver. Some other ones are, presence of diabetes, things like that. And then I didn't put a slide in here for it, but there's the last category that was mentioned is a non-case mix. And essentially nothing drives this number. It's just one flat number that's assigned. So once you have gone through that evaluation of all those categories and determined what your dollar figure is for each one of those, you add them up, and that is your per day reimbursement rate. Finally, I just put together an example here just showing you how much can be affected based on essentially just little things. So this is a category that, this is an example showing how one change in the non-therapy ancillary category can make a difference. So here, this is an example of a resident with various coding and things like that. But the only difference here is that whether the Crohn's disease non-therapy ancillary was picked up or not in the NTA section. And you'll see on a 26-day stay, the difference of coding that and not is $1,274. No, you have an right, and that's why the first 5-day assessment is so imperative, and to make sure that we have all of the data and as much as the data as possible. There are, like I said previously, optional assessments. So if there is a situation like that, or if something were to be diagnosed 2 weeks or 3 weeks later, it's called an IPA, and that is an optional assessment that is essentially the same thing as the 5-day, but you're including the things that were not originally included. We'll recalculate, and then the rate will well, go from there. There is no retro. It's just from there forward.
So this is for any resident at any time. So what happens after the 100 days?
This is for only people that are on a Medicare A skilled stay, so they're 100 days of benefits. Essentially, if someone does not qualify for a Medicare A stay, or after their 100 days, if they have a secondary long-term care insurance, or they can pay privately, or they can apply then for medical assistance.
We average about, 32 a month, 20 to 32.
Do you get good collateral information when somebody comes in to help with those assessments, or is that
It's a
case?
challenge.
Yeah, it depends.
Because I assume if you're transferring from a hospital, you would hopefully get some of that data, but not really?
We get a
Shake your head no.
we
so.
we get some, but we can't exactly say it's all inclusive. So there is a lot of work that is done in those first 5 days to gather all the information.
Did you have a question?
Yeah, so this system has been in place for, you should about 4 months now. Could you, or have you been able to analyze the old system and compare it to the new system as far as our reimbursement? Is it about the same, less, more?
CMS has stated that it's supposed to be budget neutral. We are seeing that it is on par or in cases a little bit less. In the dashboard, I believe that our year-to-date was $430. So we're within, I would say, like $75 to $100 from the old system, but there are still a lot of factors in play with the new system, such as, what day are they in? So if somebody comes into our facility and they're at day 50, in some of those categories, we didn't get the benefit of the 300% of the first 3 days for the one category, and we're already starting at a disadvantage because we're down 2% for the last 3 weeks. So we're not starting off at 100% in a couple of those categories.
Okay, so we're breaking even or a little bit less within the margin of error probably, but it sounds to me like this is much more labor intensive. So is this costing us more as far as employee time, effort?
Well,
as part of this change?
It is requiring a lot of time, but we're not seeing it's. I'll put it like this: it is definitely putting more on like the RNACs and things like that, people's shoulders. But that is also why we had requested those 2 additional RNAC positions, which the positions are currently posted. I think they just closed, but that is also the additional reason why we had requested those 2 additional positions.
Thank you.
Mr. Kusick had said that, it's been a few months that you've done. Would you say that as time goes on, and I know bureaucracy, and I know you're smiling because we both know, it takes a while. I mean, it's never like the speedboat. It's the luxury liner. And that doesn't matter who's running things. It's what it is. I'm getting the sense, your belief, and I believe it would be both of you, that over time, as people get familiar with this and they're working it, this is, in fact, will be a very efficient system for you to track all of these things.
Yeah, sure.
Yeah, okay. Thank you.
Well, if there's no further questions, I'll move on then to the other part of this where I said, so after day 100, or if someone is cut prior to that, one of their options is medical assistance. Now, as luck would have it, January 1st, our area of the state went live with the new medical assistance program called Community Health Choices, which is commonly referred to as CHC. So previously, prior to January 1st, the old medical assistance program was administered wholeheartedly by the Pennsylvania Department of Health. It was overseen directly by them. All billing went directly through their state portal, which is called Promise. The billing rate was determined by the Commonwealth, and the nursing home assessment fees, intergovernmental transfer, and disproportionate share payments were all paid directly by the Commonwealth to the nursing facility. Under CHC, essentially the entire program is still overseen on an administrative level by the Department of Health, but is really implemented and coordinated by 3 managed care organizations that have signed an agreement with the State Department of Health. Those 3 managed care organizations are PA Health and Wellness, UPMC, and AmeriHealth Caritas. All billing has to go through each one of these separate MCOs portal. They are not uniform. They kind of have the ability to request the billing in the format that each of them would desire. And the billing rate is determined through contracting with each one of the 3 MCOs. We do have a contract with all 3 of the MCOs. And the nursing home assessment fee, the intergovernmental transfer, and the disproportionate share is paid through the MCOs. The Department of Health distributes the money to the MCOs, and then the MCOs pay it to the nursing facilities.
So do you have to renew those contracts every year, or like what's the length?
The period was 3 years.
Question?
One more thing, 3 years from the date of ours, so from January 1st for us, because that's when our rollout was.
Right.
Okay.
This, with the old managed care for mental health, a similar plan that the state sort of punted it. And we then would be free, you could choose, counties could choose to either let the state find somebody or we could go out when it started and can negotiate on our own or form like we formed with Lehigh County. Are you saying that the 3 organizations, they were hired by the state, correct? So they're in charge. I mean, we're not in any way getting to pick who, the state's picking the 3.
Right.
And I guess the other question is, I'm just curious, is it set up in a way that with managed care and mental health, you get if there's money saved or somehow you get to keep it and redirect it? Now, I know it's a different system, but I'm just curious because I can sort of understand why the states punted this as well as they did with mental health. I mean, there was at least a bit of a benefit with mental health that you might have this extra money, then you can direct it where you want. Is anything like that looking like it may come down the pipe? There's not going to be any possible money. If you say, like, do they have a budget set up or an amount set up that they expect you to spend, or if you come in under a certain amount, they're going to give you an incentive?
No.
Okay, so it's managed care, but it's a totally different managed care system. Thanks. I'm just trying to wrap my head around it because this is for a whole different type of, yeah, thanks.
If I could follow up on the last point here about the assessment and the IGT going through the MCO, do we no longer have to front? We used to have to front a lot of money and then it would come back to us. Do we still have to do that, or how is that handled now?
We still will have to pay the money in, but essentially there's a different timeline involved. So where we would get the IGT money in bulk, it will be paid out monthly, starting in March, and then April, June, and then there will be a balloon payment. So we will get portions of the IGT as we go. It won't just be one portion. Now, this year, because we're in the crossover year, so CHC didn't become effective until January 1st, but the IGT contract runs from July 1st through June 30th. Mm-hmm. Half of the IGT money will follow the old format of one lump sum payment, and then the portion of the IGT funds that they're allocating from January through June of this year under CHC is paid out through the MCOs.
Okay, so this almost seems like we used to get the money all at once, and now we're having to get it throughout the year. Is that?
Correct, yeah. We're gonna get money, the IGT money from essentially March through like May, and then we get a balloon payment in June. So we should have all of that money by the end of June. It's just we'll get a little bit more of it up front in March, April, and May, and then we'll get the rest of it in June. So we'll actually be seeing the IGT funds sooner, but just not all of it sooner.
So I guess then what's if we're still fronting the money, what is the MCO's role in?
The MCO is essentially the middleman of it.
So they're just taking a cut. It sounds like that we're just as a middleman taking a, I see somebody shaking his head. So all this now is that we're still fronting, the taxpayers are still fronting the money. And now we've just got one of these three organizations taking a cut and then giving the money back to us.
The MCOs are supposed to distribute all of the funds. They're not supposed to, they're essentially the conduit of how it's getting to us, but they should not be taking a portion.
Well, but if they're holding it for
Right.
long, you know what I'm saying?
Yeah.
If they are holding the money, we used to get it all at once. They're
Right.
holding it, so there's some interest involved in them having the money longer.
Right.
Why do they get to hold it for any extended period of time? Like, why do they release it incrementally?
And I cannot honestly tell you, I don't know if the state is incrementally distributing it to them, who's then giving it to us.
We'll find out.
Yeah, right.
We'll get an answer.
We're brand new at this. I mean, I guess, do you have any feedback from the other parts of the state that it's already happened?
Yeah,
Any
they,
collaboration with them on that?
I mean, they really haven't seen a big issue with it. And later here on another slide, I talk about kind of that there is a organization that has been set up to instruct the MCOs on how to distribute these funds.
So why don't we let you keep going, and maybe we'll
Okay.
get the answer.
Wait, may I just,
Let them go through a little bit more.
okay, it's specific to this.
So,
I should just yell it out.
No, you should not.
real quick,
No, I don't.
how a resident selects an MCO. The way it happened with the rollout is each resident has a right to select their own MCO. And if a resident did not choose an MCO by a predetermined deadline, they were automatically enrolled into one of the three. The state did evaluate different factors to try to at least assign the least restrictive MCO for them to receive their services. But a resident does have a right at any point in time to switch the MCO that provides their services. So if they wanted to, really in theory, they could switch their MCO every month. If the new selection is made in the first half of the month, the effective date is the next month. If the selection is made in the second half of the month, it's the month after the next that it takes effect. Going forward, once somebody is newly approved for medical assistance, they would select their MCO to receive their benefits through once they've been formally approved by the assistance office to be eligible for medical assistance benefits. And the way that someone applies and gets approved for medical assistance benefits does not change. So the additional benefits now that people are receiving through this program as compared to the previous program, each resident through their MCO is designated what they're calling a service coordinator. This individual is specifically designated by the MCO to coordinate services for this resident. Also coordinate between Medicare and medical assistance. The service coordinator and the MCO are, through their agreement with the state, they have to create essentially a version of what we call a care plan, but for their end, essentially to make sure that the residents are receiving all of the care that they should be receiving and are also, applicable to their diagnoses and conditions. There are behavioral health benefits now. Previously, under the previous medical assistance program, there were no behavioral health benefits. Now there are, but all behavioral health benefits are administered through the county that the nursing home is in, behavioral health choices MCO. So for our purposes, that would be Magellan. The medical assistance MCO and the behavioral health MCO, essentially with the service coordinator, coordinate that, but the services are delivered through Magellan. And there is also, because another aspect of the CHC program is that they want to try to have the residents age outside of a long-term care facility as long as possible, and keeping them at home as long as they possibly can, is as safe. So if someone does improve to the point where they could essentially live out in an apartment or a home or somewhere else, but there's just a barrier such as they need a wheelchair ramp in front of their house or something like that, the MCOs will essentially give allowances to residents in order to overcome those barriers, such as having a wheelchair ramp built at their home so that they can then live back at home instead of a nursing home. The next slide here, and this is where I get into more of that assessment and IGT. The financial aspects of it are all per diem payments for the residents come through each of their MCOs once they've been approved for CHC. So essentially on a monthly basis, we send out the billing to all 3 MCOs to whoever is under them, and then those MCOs will then reimburse us. The disproportionate share, which used to be one lump sum payment based upon our medical assistance days off our cost report, is now built into a per diem rate. So we actually receive the disproportionate factor monthly based upon the days that we have billed instead of a retroactive payment. The nursing home assessment fee and intergovernmental transfer funds are filtered to the facilities from the Commonwealth through the MCOs. These monthly payments are what they're calling Appendix 4 payments. And the reason why they call it Appendix 4 is because Appendix 4 of the contract between the MCOs and the state is what basically determines how they're supposed to pay these funds. An organization called Appendix 4 has been well, no, it's another organization. They just use the same name. An organization called Appendix 4 has been formed by various organizations. One of them actually being PACA is part of this organization. And they are essentially, their purpose is to advise the MCOs how they should distribute the money once they've received it from the state to the nursing homes proportionally. And they do that through the assistance of a consultant. So that they basically on a monthly basis have a spreadsheet that they send to the MCOs and say, pay this nursing home this, pay this nursing home this. And now there is at the end of the year a reconciliation that is done because as you had said, what are other parts of the state kind of seeing now with these Appendix 4 payments? There have been some slight variances at the end of the year once things are recalculated based upon actual data. So what they do is in the following year, they will reconcile as appropriate. So if for some reason in one part of the state, they had seen that the IGT funds were actually overpaid to a couple homes. So essentially what they did is that overpayment was just then factored into the payment that they would pay to the state in the following year. Or nursing home assessment fees to some homes were disproportionately underpaid. So then they were given additional nursing home assessment fee monies in the first, I believe the first 6 months of the following year to reconcile for the previous year. So that's kind of what other parts of the state are seeing. That is essentially my high-level explanation of CHC.
To be continued.
But I did
question.
also include this packet that these couple pages, that you can read at your leisure. But this is actually a piece of information that was issued by the state regarding community health choices. It goes a little bit more into how the state is split with participants, as well as a little bit more detail on how the services are coordinated and also what services individuals are now eligible for through this program.
So who does the service coordinator contact? Where are they housed and how do they contact her? Do they deal with the RNACs?
They come in and they can deal with our social service coordinators, and they also go to the floors. So they have direct interactions with the floor nurses and things like that as well. And they also do have discussions with RNACs because they need to be involved in various meetings as well. So they really have contact with a lot of people. They don't have offices at our facility, but they're there regularly to meet with the residents and things like that.
And so there's no open enrollment, right? The open enrollment was prior to the onset, but you said they can change their MCO at any time?
Correct.
So how are the patients educated on this or collaborated with, or do you have family members that make the choice for some people based on power of attorney, or how does that?
There was a lot of information that was sent out from the state to the residents in the last 3 to 4 months of the year regarding CHC. But you're right. Some residents, like, the families had to review the information. And what we saw, and this because we're the last part of the state to be implemented, every other part of the state has seen this as well. The vast majority of everyone with the enrollment is auto-enrolled because either they haven't chosen an MCO by the deadline or, they didn't have someone to make that decision for them. But that's why the state would then pick an MCO that was least restrictive for that resident with the services they were currently receiving and things like that.
Since I made you wait, go ahead.
No, I mean, you asked actually part of it. Yeah, and you know what? Thank you. Actually, both these were presentations. I mean, I was very impressed. And I know it's just all starting, so it's going to take a while. Especially with this health choices. I don't know where to start. I mean, so you have a patient. I know mental retardation went down this road. And they said, you can pick whoever you want. The county would provide. So then it was you want you to have the choice. Of course, then it got into who's making the choice because some of the folks weren't in a position to really make an informed choice. And I guess my concern is, short of a very invested family with paperwork to back it up, I know anybody who's in the position of, especially an older boomer who's helped parents through final years, you get bombarded with the paperwork from insurance companies and that. And thank God if you have someone to help you, because there's the idea that some of this stuff can be figured out by somebody, even if they're technically by the courts competent, is just insane. And I'm just nervous about how this is going to be administered by a resident of a nursing home. And how often do they have to? I mean, if let's say I pick a particular MCO, how often do I keep that until I make a decision that I want to change?
Right, yeah.
So if somehow my bedmate says to me, my bunkmate says, hey, you know what? We've got this one, and they're a lot better. They give you ice cream as part of the reimbursement. And I'll go, oh, I want to change. Is there any review process to say, wait a minute, do you know what? Because you have to, unless there's some paperwork or something, you've got to go with this. Right. So this could potentially be a bit chaotic. And managed care, let's be honest, managed care means managed cost. That's what it was for mental health. That's what it was for MR. And I know you had the question before, do they get any money? These and I call them insurance companies. These insurance companies aren't doing this for free. I mean, as I used to tell the Magellan guy when we first negotiated, we don't mind putting your child through private school, but we're not paying for that new Mercedes that's parked out front. And for the life of me, I don't know how this can work. I mean, I know what the state's game plan here is. They want to punt and save money ultimately. Ultimately, though, what they're trying to do is squeeze you guys. And it'll start, though, and the MCOs are going to come in and squeeze you on payments. I mean, I'm not going to get into it because I want to see after a year how this has worked out for you, because I don't know. And I know you prepared us for this, and you were telling us for a long time, so I'm not going to deny that. I mean, you seem like you're doing everything you can do. I guess I'm just jaded by the county's past history with managed care. And I guess this is for all nursing homes, right? Not just public, private?
For any nursing homes that are medical assistance eligible.
All right, so if you take MA, and the service days, I had a question before, but just to go back to that, I know you get more up front, but you may get people who were at a place that doesn't take Medicaid and then they can't use it, so they'll bump them to you, but you can't take advantage of that upfront time when there was more money or something like that. So
it's a standard per diem rate.
Yeah.
With the CHC program, there aren't increases.
Oh no, the CHC, but I was going back to the original.
Exactly. And that's why
you're at a bit of disadvantage on that.
Right. Facilities look at it, and honestly, those first 3 days are key because that's where you're getting your most.
And if I may, Madam Chairman, I just want to say I appreciate what you're doing here, and a plug for Gracedale. I don't know if anybody puts out as much detailed information as you do as a public agency. I don't know if anyone noticed, but there was recently settlement announced by the state with a major corporation with a local nursing home, private, who were billing residents for, I believe it was therapeutic services that were not necessarily needed, but certainly people were told to talk about how you can maneuver people into things. You should have this therapy. And I'm not going to mention the local home that's involved, but I mean, this is good. You put everything out there. So it's not a panacea out there in the private companies. They get caught now and then. But I'm waiting to hear more about this. I mean, I wish you luck. I have to be careful because my experience with managed care was, it's just, oh my gosh. But I honestly don't know how you're going to, I mean, I'll give you credit. I don't know how it's going to work out at a facility, this type of population. I mean, it'll be interesting to watch it unfold, and I hope for the best because you have one of the most vulnerable populations. And, I know a lot of your folks, people talk about family, but a fair amount of your folks don't have any family coming in. And good luck. I'm done.
Was there a question?
Yes, there was. I asked about 4 questions. Do you want me to come up with more?
No.
Ron,
I heard a lot of
You know what a
comments.
certain councilman used to say? Do you want me to come up with more motions? I could come up with 5 or 6 motions.
Did you have a question?
No, I'm fine. Thank you.
Are you concerned, given what Councilman Heckman just said? Or, I mean,
it's probably more from the service than he's a numbers guy. I mean, I'm concerned
But that's-
more how the finances, not how the service is going to work out.
We're the middleman. So the hospitals are the most expensive. The nursing home, they consider the middle. And then if they can get you home, it's the least inexpensive. But when you look at our population, they can't be home. So I don't foresee, maybe a couple of people who maybe should have gone out anyway, and they weren't, but they'll be back.
I mean, if it was really as simple as a ramp in front of your house,
Right.
that's lovely, but I
They're not taking the medication. We had a resident come in because she required home health. Well, there was no home health aide to serve her, so she had to come to the nursing home.
I know when we first heard about this, I think some of the concerns we had were, would they be really micromanaging and trying to get people out, or like really digging into people's cases to try to
Well, we
not
asked
have
them
a
that.
length of stay or whatever, but
They
I
said
just-
not. Right.
Madam Chairman, would you indulge me?
No, I'll definitely indulge you. No, of course I will. Go ahead. You put it out there.
You just said, though, one of the things, and I forgot, because, well, no, you had, right. The idea that they do want to see people go to the least restrictive.
Right, which is home.
Which is home, but I mean, sometimes these homes aren't there.
Right.
And I mean, let's say someone has an amazing turn, but you've already dumped the house. So you're going to have to go find an apartment. And again, here's where we go back to mental health. And I'm sure to this day, Sue's probably even seen this. When we got rid of the state hospital, everything was wonderful. There were some people you could put out on the street with private vendors. There's no question. But then by the time you got to CHIP 2, and CHIP was the acronym, I'm sorry. Right. But it basically was 1, 2, 3. You got to the point where there was no question these folks without heavy, heavy supervision weren't going to make it. And some of the people you see on the street now are some of those wonderful recipients of the CHIP program. And the state and everybody patted themselves on the back because they saved money. But, I mean, the vendors weren't keeping up with them. Some of them were getting the check and saying, hey, did you take your meds? And the guy's screaming, yes, I did, yes, I did. They go, thank you, put down the note and moved on. And I guess my thing is this idea that somehow these folks in the nursing home, I mean, I get it. There's probably some people that could be moved out. But I think you would agree, you're going to have, it's a whole different population. Correct. I guess that's where, and I'm sorry, it's just that I lived this for so long. I can't help myself, and I apologize. It's just, I'm stepping into Sue's turf, and I do apologize. But the thing is, it's just, I don't know how they, I mean, this is incredible to me, especially with this population, that they're even conceiving of this idea that, well, you're going to hold on to people. And I can see where they're coming from. Somebody there made their dollars by saying, you realize they're holding on to some of these people to make money, but we could serve them out in the community. Show us the community support systems that you're going to put them into.
But you
That's
also,
it. I'm
if you
sorry.
wanted to be an optimist, you could look at it like it is a way to cut waste. It is a way to cut fluff. So it is maybe more patient-centered. I mean, like, I know Medicare doesn't like to pay for anything and all, but I don't know. I don't see that I don't see.
Patient-centered policy.
No, but like I said, if you were being an optimist, you
I'm
know, you
sorry.
have to try to.
I guess I walked through the swamp too long to be an optimist. Sorry. I hope it works out. I do. I really do.
Again, I asked Brian, do you have any concerns?
Yes.
Because I think, like we've planned, I know the RNACs are ready. I know that the team has been planning for 1.5 years to capture every dollar, to get every diagnostic in place to do it right. So like seeing that in my mind makes me feel more confident. But how do you feel?
We actually are in the midst of sending out our first billing through this program. There was, so we do have PCC now. Another aspect that we've been working on with an integration is called a company Ability, and it's a kind of a medical billing conduit program that integrates with PCC, and that program should, from what we're hearing, help us with this billing, because like I said, now we have to bill to each 3 of the MCOs that each have their own formatting, clearinghouses and such, but this program will essentially help us with that formatting. If we were billing straight out of point-click care, I think we might see some more issues. Again, this is our first billing cycle, so we'll have to see. But I think that will help, as well as, we just have to do a monthly check on residents to see what MCO they're with, because, like you said, a resident can switch MCOs. So if we bill the MCO that we thought they were with versus the one they're actually with because they changed, that'll cause a billing issue. But we'll have to just run like insurance verifications and things like that.
We're going to run out of time, so I wanted to let you have time. Thank you very much for all the prep you did. I'm sure you can come back and give us some updates on this, but thanks for the overview. But we wanted to just briefly get to the dashboard, if there's any key points that you think, because you had the survey, in terms of just census or costs, or how this relates to that.
Yeah. All right, I'll just run through the first couple pages here real quick, and then I can kind of get to the side for Jennifer to go through some other stuff. Just some real quick information. For December, the average census was 644, with the facility year-to-date average being 654. The cost per resident day for December was $316, with a daily average for the year at $341. PPD was 3.25 for December, with the total annual average for 2019 being 3.37. And our Medicare per diem rate through December year-to-date was 431, and the room and board portion was 335.
Do you know what the census is today?
It is 628.
628.
The revenues for 2019, the monthly average was 5.2 million, and the current year-end total revenues for 2019 were 80.7 million. Expenses, the monthly average was 5.7 million, with the total year-end expenses being 81.7, and then the net position with that is 4.4 million.
We discussed that already, though, right?
So you can look on page 3, the admissions and discharges. So in 2019, the admissions for the year were 467, and that is up from 2018 at 428. And the discharges were 484, where the discharges in 2018 were 427. So we are bringing in people. Good news is they're going to the short term, so they do equal more money. However, we're not getting in the long-termers in a little bit. So that is where we're hitting with the marketing. They're coming in. A lot of them are just not ready yet. They come in, they do the applications, sit down and work on the Medicaid, and they're just not ready. Staffing and call-outs, we had 9 new employees for the month of December. We had 12 terminated employees for that same month. The year-to-date call-outs were 6,045. Of these, 29%, or 1,734, have been FMLA or IFMLA. Again, the trend creates barriers for us, but we are working with our recruitment specialist. We are hitting the ground running, trying to recruit more people. Staffing, while LPN vacancies are up this month compared to November, they are less than the RN and CNA categories. The workers' compensation on page 5, December had 5 claims, the same as November, so that hasn't changed at all. There were 7 claims for modified duty in December, the same as November. Again, that didn't change. We continue with safety first, and as Sue has said, we have a new risk manager who's doing a fabulous job. Wounds and infections, you can see the month-end wounds count for December was 36. That is the lowest we have ever been. We are down by, that was down by 9 wounds over the last month.
Ever?
As far as Candy, who is in the medical department, said she had seen.
Cool.
That's what Candy was saying.
That's good.
From when, and that could be from her calculations. She's been in that position at least, I would say, 5 or 6 years. Infections at Gracedale were lower in December to at 80 compared to 64 in November. They were, higher than compared to 64 in November. And again, December, cold season. Urinary tract sepsis and skin and soft tissue infection category showed us an increase in December compared to November. The number of respiratory tract and GI tract infections declined. In November, overall, 19% of all the infections required reporting. We've seen just the norovirus, a little bit of it, so that puts people out of commission for a little bit. Healed wounds, we had 16 healed wounds at Gracedale this month. 24 wounds are no longer being tracked due to discharge or resident expired. Again, we're working together as a group. We have some RNs that are coming in the evening hours and making sure people are being checked and changed and turned, repositioned. They're just doing audits left and right, making sure everybody is counted. Incidents to watch. For falls, we had 171 falls in December involving 107 residents. So there were some people who fell multiple times. Injuries of unknown origin were 51 in December. So the overall incidents are up to 318. The number is below the 338 year-to-date monthly average for Gracedale. So we again trended below. Accidental self-infliction injuries were down 8 this month to 17. This is below the monthly average of 22. Again, we always strive for training and safety. Quality measures. You can see the things that we do better than the state average on, and there are, on the right side, some things that we're going to be working on. So again, we're working with Dr. Holmeser, who came in here. We're working for the short-term quality measures to increase. That's our next challenge, but we're gonna take that on and make sure that our numbers get up, get those stars back.
Okay. Any quick questions?
Yeah, just, I think my concern here is the census situation. We missed the target for last year, and when I just heard that number, 628, that is nowhere near the target of 670. Do you have any idea why we're struggling to keep the census? I mean, because well, this is December, I kind of thought, well, maybe it was Christmas, holiday, but not now. Why are we struggling to keep a census?
It is, we've had a lot of deaths. Just yesterday, we had 5, one more today. So that has been a struggle. Right, we can't control that. We are marketing. We are diligently working. We are looking at those that we turn away. We work with the hospitals that if they're not ready to come to us due to maybe a behavior or we had one that had an infectious disease that we could not handle, we work with them. As soon as the hospital clears them, we take them. So they are coming in, they're just not coming in as fast. And we are not getting the people who are at home. You know, they're going home from the hospitals, and we're waiting to get them after that.
So I guess then to follow up, I mean, we've been through this before, and if we can't keep up a census, is this a point where we should be looking at selling beds and reducing that number? Because, you know, we do have this 4 in a room situation. Would doing something like that make the place more attractive to customers? I'm just thinking out loud here because I think we have a census problem.
We do, and the admissions department is doing a great job. They're bringing the people in, but they're bringing a lot of short-termers in, which again is more money. We need to concentrate more on the long-termers. So are we at the point now where we need to do that? No, not at all. And we can't make improvements to the nursing home yet because we still fall under the life safety. So if we're talking rehabbing any part of Gracedale, we have to follow the new rules. So if you take a 4-bedded room and you do any electrical work or any construction in it where you're displacing residents, you have to go by the new code. So now you're breaking it down to 1 person in a room plus they get a bathroom, or 2 people in a room, and every room has to have its own bathroom. Mm-hmm. And that would be a major overhaul.
Yeah, well, I was here for the window project,
right.
So I know what can happen, and it goes downhill real quick. The other part, simple math, it looks like expenses exceeded revenue by $1 million. So for 2019, it looks like we ran an operating deficit of $1 million. Is that accurate? And you know, is that something you expect to continue? I know we said the food carts, but I can't believe that the food carts.
We put money back into Gracedale, which hasn't been done for such a long time. You know, every little thing that we do adds up, whether it's point-click care, the food carts, painting, giving the residents the community room that they wanted. We just got a pool table in from one of the senior centers. Everything we do is we're finally giving back to the residents, whether it's a paint color. We haven't had that in so long. New furniture we bought. We were dealing with furniture from the 70s. Who wants to walk into a nursing home where you still have, you know, Harvest Gold or Green? We updated it so that they come in and see that we're investing in their stay here. And that's what we want to do.
But that's not reflected in the census. So, you know, just to go back to that, my hope is that these operating deficits don't continue. I understand you do have to reinvest in the facility, and we continue to do that. But this is the first time in 4 years I've seen an operating deficit. So I'm hopeful that we increase the census and reduce this deficit.
And I can tell, as being the admissions director for a very long time there was a point in time with, again, negative publicity that we had for a long period of time last year. It takes a lot of time to recover, because I can tell you when I was admissions director, we had 2 months where I was told to slow admissions into Gracedale, and it took me about 4 months to recoup, and that was about 3 years ago. So it's going to take time. We have to talk to the hospitals, and we have that open conversation with St. Luke's. We just met with them.
She's far taller than I am. And wears heels. And I think the other important piece with the financials is we've staffed Gracedale last year at a much higher level than we did previous years. I don't have the breakdown of those numbers, but I mean off the top of my head, but I know from conversations that we spent a lot more money than we did the year previously to have staffing where it needs to be. So that's also, in addition to all the improvements and upgrades, as long as we're going to staff it adequately, it's going to cost us more money, and we all know that. But that's a big piece of that, I believe, as well. So I just wanted to add
I'm at the time, so I have to end. Thank you for everything, and with that, we'll adjourn.